This is chapter 26, the child with genital urinary dysfunction, and part 2, we're starting at external defects. So phimosis is a really tight tip to the foreskin, so the foreskin cannot be easily retracted. This is normal during infancy and toddlerhood, and in fact it should not be retracted until it has loosened up, somewhere usually in the preschool years. And then it can be retracted and cleaned underneath, but prior to that it should just be left alone. Inguinal hernia we talked about in the GU chapter. This is a loop of intestine that comes down through the inguinal canal into the scrotum. Hydrocele looks very much like a inguinal hernia because you get a large scrotum on one side. The difference is hydrocele is fluid in there instead of a loop of intestine. Cryptorchidism is an undescended testy, and it can be one side or both sides. This takes surgery to pull down that testy. We don't like to leave it up in the abdomen, the pelvic area, because it's at a higher risk for testicular cancer, also tends to cause infertility. Hypospadias means the urinary meatus is not at the tip of the penis, it's along the bottom on the shaft. Epispadias means it's along the top. Both of those require surgery to correct it, to move it to where it should be, so that you have a little boy who can pee standing up, which is normal for a male, and also to have a sexually adequate organ, so that later in life ejaculation comes out the end, not just some top or bottom. To do that surgery, if it's just a little bit off from where it should be, they'll just simply move it. If it's a long ways off, they may have to make urethra, and what they like to use for making that urethra is the foreskin. So on these little boys, when they're born, we need to not circumcise them so that they can use that tissue later if they have to create urethra. Exstrophy of the bladder. This is a bladder born outside the abdominal wall. So it's obvious at birth, often can go with some other defects, so it needs to surgically be reinserted, but sometimes that happens in the first few days of life, sometimes not till a few months of age, especially if there's other things going on that they have to be concerned with at the same time. So that will require surgery though. And then ambiguous genitalia. This is a child where it's not clear at birth if they have male or female genitalia. Usually this goes along with other defects, and so they'll do genetic testing to figure out what is going on, and also to identify what the genetic sex of the child is, and then they can surgically create that. And often there are other issues, so often there's hormonal treatments that are needed as well. So here's our inguinal hernia, if you remember, a loop of intestine that slides down here. In a hydrocele, it's fluid. And a hydrocele, most of the time, will resolve on its own. We just watch it, and on these little boys, usually within the first year of life, it goes away. Occasionally, they call it communicating, so it's connected to higher up where the fluid can come in, and so if it doesn't go away, then it does need to be surgically drained and that area of communication sealed off. And here's how they can tell the difference between a hernia and a hydrocele. If you shine a light under it, you'll illuminate the loop of intestine, and this you don't see it, so that's just a hydrocele. Hypospadias, here's our meatus down here instead of up here, so they've got to surgically correct that. Usually they'll wait till a child's getting close to a year or so to do that. And here's exstrophy of the bladder. As you can see, it's moist, right? It should be an internal organ, so we're going to keep it covered and moist and protected until it is reinserted. Their goal is that this child is able to have normal urinary function and be continent, and sometimes that takes more than one surgery. So moving on, nephrotic syndrome. This is characterized by massive proteinuria, so dumping a lot of protein into the urine, and hypoalbuminemia, low albumin in the blood, because albumin is protein. We just dumped it all out in the urine. When you don't have albumin in the blood, you get edema. If you remember, albumin is the main blood protein and has a strong oncotic pull, pulls fluid into the intravascular space, and without it, you're not going to pull that fluid in, so it's going to go out into the tissues and cause edema. And then along with those, you get hyperlipidemia. So with kids, we're almost always talking about minimal change nephrotic syndrome, which means it will run its course, pass, and not leave any permanent damage. So it's sometimes also called childhood or idiopathic, but that's what most of them are with kids. Our most common age is 2 through 7, and what happens, that glomerular membrane becomes permeable to protein. It's supposed to be impermeable to protein, and it gets damaged to the point that it allows protein to pass through. Hence we have the proteinuria. And because we've lost all that protein from the blood, we have the hypoalbuminemia. And because we don't have the protein in the blood, we get fluid shifts causing edema, and ascites is just edema of the abdomen. We do need to be careful that they can be hypovolemic because they don't have the circulating blood volume because that fluid is not there. Here's a little schematic showing our glomerular damage, dumping protein into the urine, so it's not in the blood. Body's response to that is to make those high extra lipids and extra proteins. So then without that oncotic pull, we get edema, we get hypovolemia, which in the long run kind of leads us back to that edema as well. So how are we going to take care of this? Well, just supportive care. This child's uncomfortable, they're edematous all over, they're just sort of miserable. So supportive care, but the main treatment is steroids. We're going to start with a fairly high dose, 2 milligrams per kilo, and divide that into 2 different doses a day for at least a month, 4 to 6 weeks on that dose, and then they'll lower the dose maybe to once a day or even to every other day, and they'll continue that for months, for 2 to 5 months. So our minimum treatment is 3 months, and probably more likely closer to 6 months. With that, they may restrict protein and sodium in the diet. They may try some other immunosuppressant to try and help that glomerular membrane heal. Diuretics may help with the edema, as might giving IV albumin. Not likely to put this child on a fluid restriction though. Even though they're very edematous, they're intravascularly low volume, so we're probably not going to fluid restrict them unless something else is going on. What we do need to prepare the parents for is these kids often will have a relapse, or they can have a relapse, and so as soon as any symptoms are seen, we need to start them on steroids to minimize the next time. So here he is, just miserable and swollen all over. Similar but different is glomerulonephritis. Now this usually happens after a strep infection. It can be streptococcal pneumoniae or your group A beta hemolytic strep, but either way a streptococcal infection. And what we're going to see is edema, like with the nephrotic syndrome, but with this we have hypertension. With nephrotic syndrome we don't, and that's because we have lots of extra fluid, because in this one the glomeruli are not pulling off fluid. So the edema, the hypertension are from extra fluid, and because it's not being pulled off, we have less urine. So oliguria, what urine there is, has blood in it, hematuria, but it's not frank, bright red blood because it comes from higher up in the kidney, right? So it's going to be T or cola colored. And we're also going to see protein in that urine. And the more protein we see, the more severe this is. So how do we manage this? Because this one has that high blood pressure, we've got to monitor the blood pressure. With both of these, we have edema, so we should be doing daily weights. That's our best indicator of how much fluid is being retained and lost. Accurate I&O, daily abdominal girth for the ascites. On glomerulonephritis, nutritionally, we do want to use low sodium and low to moderate protein in the diet. This is going to make them very susceptible to other infections, but we don't need to keep these kids on bed rest. So I always have trouble remembering which is which on these. So here's a mark all that apply question for us. So if you think about your mark all that apply questions, they are just a list of true-false questions. So we're talking about minimal change nephrotic syndrome. So does that one have blood in the urine? And your answer should be no. That would be glomerulonephritis. How about protein? Yes. Remember, you dump out protein. Hypertension. No, that is glomerulonephritis, not nephrosis. Edema. Edema's, yes, happens in both. How about hypoalbuminemia? So, low albumin? Yes. Moving on, hemolytic uremic syndrome. This also usually occurs after an infection. Either E. coli, Shigella, Salmonella are the common causative agents, but we get toxins released from these bacteria that do damage. And what happens is the glomerular arteries or arterioles swell up, and those get occluded with platelets and fibrin clots. And because the platelets are all getting used and plugged up inside the glomerular arterioles, they are not out in the bloodstream. So we're going to see low platelets. Those plugged up arterioles, then RBCs get stuck in there and get damaged and get broken apart. So we're going to see anemia, but we're also going to see broken RBCs. So our diagnosis is based on anemia, thrombocytopenia, and renal failure, because the glomerulus cannot do its work of pulling off fluid because it's all plugged up and it doesn't have good blood flow running through it. So our treatment while they're in renal failure is to do dialysis. We typically do peritoneal on children, and if that doesn't work, then move on to hemodialysis. You may need transfusions, fresh frozen plasma to get those platelets up, maybe plasmapheresis or packed RBCs, but just depending on what the child needs. And we said that you're going to see broken red cells when you should see all whole red cells. What is not on the pediatric exam is renal failure, dialysis, or transplant.